Sure. So let me pull these up. So I think it was really great. The talks were really, really great. And there's numerous questions that I think that our panelists have great expertise in. So I think we'll just start with going down the line, which is, do you have any experience in treating neurofibroma with microwave ablation?
Yeah. Once again, neurofibroma is a benign lesion. It can be treated with microwave ablation. You will need an anesthesiologist to be there present. The patients are in real pain. Honestly speaking, we prefer cryoablation for this kind of lesions. I think there is a tendency to use cryo simply because it's more friendly to the neural tissues. There is some experience with radiofrequency. The least experience is with microwave ablation. You can find in the literature a couple of case reports for microwave ablation. We have tried that once. These lesions, in the vast majority of the cases, they are small lesions. It's like trying to kill a mosquito with a cannon when you are using microwave over the other ablation techniques.
Is there anyone else who wants to comment on the neurofibroma from our speakers? Sean, your microphone. You should open the microphone.
Thank you. We've been using cryo predominantly for the same reasons. It's less painful. You can get good reduction in the size of the neurofibromas. And so, that's been our preferred tool for those patients. I've only treated a couple of patients. We've also treated some plantar fibromatosis, so in the spectrum of like desmoid tumors, and that responds very nicely to cryo as well. But I'm sure you could use microwave. It's just, I think Dimitri's analogy is a good one.
Okay. Sorry, please.
For desmoid tumors, with surgeons, you usually do surgeries before, but nowadays we just try to do less surgeries because most patients could just, if you do not do surgery, the patient the tumor progress very slowly. If they had a painful or functional problem, then we can interfere. Otherwise, we just stay and watch. So that's the difference. That's the difference between before and nowadays. Thank you.
Thank you. So we have a question for the spinal lesions. So one of the people listening said that one of my spinal leading meds had post-RFA bladder dysfunction. I am hence worried how to avoid coda injury. This for Professor Zhang, if he can hear us, if he can comment on it. Is he here? Is any of the other panelists wants to comment on it? Oh, wait, we are having, yes.
Yes, Dr. Wu is here.
Okay, so the question
You're
is—
muted. You need to unmute your microphone.
Okay. You have to open the microphone. How would you avoid spinal coda injury? How would you avoid neurological damage when you do ablation in the spine?
When we do the ablation in the spine, we use the low power of the ablation. Maybe it's 20 watts to 50 watts, and the lower short time. And we make the CT scans and ask the patients how he's feeling, and we prevent the spinal cord and the nerve prevent the spinal cord and nerve injury. That's all.
And have you seen any such complications with microwave? Any neurological complications with microwave?
就是你在手上有没有出现过这种并发症？有没有出现过？
相对比较少。 it's very very 很少。因为我们选择的适应症都还是比较好，并且是一些肿瘤晚期的病人，所以就是说，我们通过术前跟他的一些充分的沟通，我们能够避免一些医患的纠纷，并且我们每次做的时候，我们每次的消融时间大概都掌握在是以30秒，是以就是说很短的时间为一个单位的，所以我们在手术当中会不停的停止，然后再继续，停止再继续。这样子的话，我们首先病人没有一个很高的一个要求，然后我们只是说缓解他疼痛的一个症状就 OK 了。Thank you
谁翻译啊？南京医高翻译吗？还是谁翻译？
你帮我翻译一下可以吗？
我帮你翻译。OK OK
Thank you.
The doctor said that they got very few cases that got complications because they highly selected the cases. So only those cases that with the very low possibility of the complication, they would do this kind of technique. So otherwise, they would not do this kind of surgery.
When we do these kind of cases with microwave, we usually either use active neural monitoring in order to verify the neural response when we do the ablation with microwave. And at the same time, we try to avoid cases where we have a posterior compromise of the posterior wall, because then you have a less protective barrier. So this is, again, one of the reasons when we choose microwave or other ablation devices. When we don't have a posterior wall, we choose a less aggressive ablation device. When we have a posterior wall, we will use a more aggressive ablation device, but we will always do an active monitoring of the neural structures. Before we continue to the next question, I would like to thank, first of all, ECHO for providing the sponsorship for this program and for this webinar here. So I would like to thank them very much for being very efficient to provide this platform where we can all be together from different continents. So it's very important from having people from the US, Europe, and China, and Asia in one session. There is other ways also to the previous question, also to complement that there are other ways also to protect the neural structures. You can use either gas, CO2, or air, or even liquid in order to protect, and put also thermocouples to do neural protection. David, do you want to take another question?
Yeah, so one of our participants, or attendees, I should say, is asking, how do you calculate the volume of bone cement for vertebroplasty?
他是问你，就是你怎么计算你打多少这个量，就是骨髓原量。
这个我来回答，麻烦你翻译一下，徐教授。
没问题，没问题。
他是问你这个，就是说骨髓泥注射的这个剂量是多少，是吧？
对，他怎么计算？就怎么去计算它？你要打多少？
我们打骨髓泥有一个原则，一般来讲哈，在骨髓泥不向椎管和椎间孔渗漏的情况下，尽可能的多打，使这个骨髓泥呢能够覆盖整个这个尽量的覆盖这个肿瘤区域。
不是计算，是手当中直接看是吧？之前不计算，是手当中就是你要 CT 不停的去扫描去看它去检查它。对。Okay, I will translate for the Professor Zhang, and he said that they will not calculate before the surgery, but during the operation they will use the CT scan to monitor the tumor and the space. So the cement has to fill the cavity of these lesions. So just continuous monitoring. So until all the spaces are filled with cement, then that will be okay.
So in order to have, this is the answer. The question is not about volume of cement, but about dispersion of cement and distribution of cement inside the lesion. So you want to fill as much of the lesion and to avoid as much as you can of the surrounding structures. And in order to have a good support, you want to fill from end plate to end plate and through the middle line to have a good structural support specifically for vertebroplasty. So it's not a question about volume, but more of a quality and distribution of cement inside the vertebral body. There's another question. Sorry, Sean, you wanted to say something?
Well, just to add, in osteoplasty and in the pelvic experience, when we began, we were routinely injecting too little cement. We were putting in cement and kind of getting out, not wanting to have complications. When we started using navigation, we could actually calculate the volume of cement that would tell us what would likely need to be injected. And my orthopedic colleagues would push me and say, no, you need to inject more cement, which I think our orthopedic surgeon would appreciate, is that, if you don't get enough cement in there, you're not getting that structural support.
Okay, thank you very much. There's another question about the type of biopsy needle or biopsy trocar or insertion needle used for microwave. Is there a specific needle that we need to use when we use microwave for ablation? And what should we do in order not to have needle issues? So for the outer needle going in, do we need to take some specific care? Is somebody who wants to pick up the question?
Yeah, I'll take it. You can use any kind of bone trocars as long as you can penetrate the osseous cortex and reach the lesion. As far as microwave is concerned, you do not want the active tip of the microwave antenna to touch the metal. So you should move away the trocar once you have the antenna inside the lesion, at least a couple of centimeters away from the active tip. That's the main difference. You don't want the metal to be in touch with the active tip of the antenna. As long as you have that, you are safe to go for the ablation.
Okay, can I ask a question? Yeah.
Of course.
Sure.
For the osteoma, do you routinely do the bone scan before the surgery? I mean, the ablation?
You mean CT scan?
No,
or bone scan.
Bone scan.
Yeah.
Routinely do this, right? No.
We don't use bone scans anymore. The patients, they come to us with a CT scan. We can see the nidus, and the diagnosis is coming from the imaging. Some of the cases, because they're very young patients, they come first with the MR imaging, and then you might need a CT scan. But we don't use bone scintigraphy anymore. Before the treatment, actually during the treatment, we always start with the first CT scan to select the access site, the root of the needle and everything, and then we carry on with sequential scanning during the ablation.
Okay, so I'd like to...
If I can help with that also. Some of our patients are coming with their bone scan, but we do not do the treatment on the bone scan. We need at least CT and MRI. This is because many times the pain, specifically for osteoidosteoma, is very diffuse. And one of the one of the diagnostic procedures that can help us identify that there is an osteoidosteoma is the bone scan. So many people will come for the diagnostic part because they have a diffuse pain or they have a pain which cannot be seen otherwise. They will do the bone scan, identify the region, and then will come with an additional CT and MRI. Nowadays, as Dimitri said, people are moving more and more away from the bone scan and more in the MRI. I think this is a preference of the West, at least in our region of the world. I'm curious to hear about the US, but people are moving away for this type of lesions, away from the bone scan and moving towards the MRI imaging. And then from the MRI, sometimes we will follow up with a CT in order to identify the nidus better.
Okay, totally agree. Can I share a case with you? Because I just searched from our database. Okay, just I guess just several minutes.
Okay.
I'm sorry that because I do not prepare for this case yet, so it's still in Chinese. You can see that the patient got a knee pain, that is a medial knee pain, 4 years. Then the patient received X-ray. You can see that there was a lesion posterior of this femur. You can see it. And the patient also complained there is sometimes there is a liquid pain, but most of the pain located in the left medial knee. And then with the patient received a CT scan, you can see there was a lesion posterior. So, but we evaluate the patient. You can see you can fix the physical examination. You can fix the left femur. The left side was less strong than the healthy one, the right one. Then we perform the CT scan. Then we find that there was actually more significant lesion actually in the proximal femur. You can see. Then we take an X-ray here. Then we see that there was a lesion. There was an osteoma in the proximal femur. Then we surgeons usually do the surgery. So this is computer navigation guided surgery. Remove the tumor nidus. Then this is the pathology. Then we use this artificial bone filling. So then we go back to the X-ray of the knee. We can see actually this was not the osteoma. I mean the distal femur. That was a non-ossifying fibroma. So the symptom was not caused from this lesion. Actually, it's from the proximal femur that causes the optic nerve. I think that's what I want to share with you. Thank you.
Thanks. That was a great case. So we have another question. The question is basically that Demetrius mentioned that he used, in his case, local anesthetic and dextrose as an insulator. The question is, does local anesthetic alone serve as an insulator, or does it transmit heat?
It depends on what you're using. If you're using radiofrequency, local anesthetic alone will not transduce heat. If you're using microwave, what you want is not to have any kind of fluids close to the active tip of the microwave antenna. So if you're having an antenna with 0.4 centimeters length of the active tip, you should not have fluids at a minimum distance of 0.4 centimeters. If the length of the active tip of the antenna is 2 centimeters, you should not have any kind of fluids close to the antenna at a minimum of 2 centimeters. To answer that, if you are using radiofrequency, which is the gold standard for osteoidostoma, you can use local anesthetic in order to increase the distance from the skin. That will suffice. If you want to increase the distance from a neural structure, you should use dextrose 5% for radiofrequency.
Thanks, Demetrius, for that excellent answer.
I think we have one or two last questions. The other question we have is, what about osteoblastic, osteosclerotic bone? Can we treat that with ablation? Do we treat that with ablation? And specifically with microwave. So is there somebody who wants to take up this question? Sean, for the pelvis?
Yeah, so I had a case that because of time constraints, I didn't show it. We definitely can treat osteoblastic lesions, and we can treat them with microwave. I've had a little trouble with RF. I don't think that the energy deposition is quite as good with RF, so it's either microwave or cryo. The thing I would caution you is that if you look at the Morell's scoring, you still get 1 point for an osteoblastic lesion, and you can still have a fracture because that bone is not normal quality bone. It's brittle, right? It's pathologic bone. And so I'll even attempt to augment those if I think I can, despite them being osteoblastic. And you'll often be surprised that there's areas of mixed lytic, blastic, and you can get cement in there. So I've augmented those.
We use microwave in 100% of all our osteoblastic cases.
So that is a good use for microwave, specifically because, as Sean said, RF has a lower energy distribution in sclerotic bone because you get a higher resistance. So the resistance goes up in the sclerotic bone, then the radio frequency cannot close the circuit in order to produce the energy needed. I think this is pretty much as I have with questions. David, do we have anything more?
Well, it looks like there's one last question, which has to do with how you calculate the microwave power and time to prevent intraspinal spill of cement during microwave and osteoplasty.
This is Sean. Do you want to take that one?
I would probably defer to Dr. Zhang because based on his talk, I think he's thinking about it and calculating the time and the wattage. I use similar wattages and times, but I'm thinking more about the size of the tumor rather than the protective effects of microwave and leakage. So I would defer to Dr. Zhang.
When we do the ablation and injected the bone cement, we do not calculate before the operation. Every time we do the operation, we must very, very carefully, and we must every time make the ablation, maybe the lower power and ablated for 1 minute or 30 seconds. We stop and we make the CT scan and ask the patient's feeling. And when we inject the bone cement, every time we maybe injected 1.5 milliliters or 1 milliliters, and then stop the inject and then make the CT scan until the last. Maybe we have the principle that when the thoracic vertebrae, the bone cement amount is not more than 6 milliliters, and in the lumbar vertebrae, the bone cement maybe it's lower than 8 millimeters. And every time we injected maybe just 0.5 millimeters or 1 millimeters, and then we make the CT scans. If we found that a little leakage out of the vertebral body, we must be stopped. And if we make the CT scans, we found there is a little, maybe there is also have the also have the space to inject it. Maybe we injected more bone cement. That's all. So okay. Before the aspiration, not calculated.
If I can help also to add to that, microwave has specific guides that they come with specific maps of energy distribution. And also with microwave, you can be additive. So you can do 1 minute, see the nerve response, then add another minute. This has an accrual. It's not like an RF that you have to do a continuous ablation. You can do sequential ablations with microwave and increase slowly the ablation zone by doing 1 minute and 1 minute and 1 minute in order to get the complete image. And as we said, we use the protective measures too. Now, between the ablation and the cement, it's better to have some waiting time, because again, you want the temperature to drop inside the lesion before you start injecting the cement. Otherwise, you will have a very hardened cement very quickly. So that is why you inject a little bit and wait, and that will gain you time to make the temperature inside the vertebral body or bone drop before you start injecting. I don't know if anyone else wants to add something to that.
Maybe what's sorry?
Sorry, I think there's one question for Dr. Zhang. Can we have a brief summary of microwave vs RFA prognosis and pros and cons in the spine? I have come across many people near me using RF ablation, but not microwave, but the panel seems to have good results with microwave. 这边的话，请张主任大概的讲一下，就是在那个脊柱这边消融、微波消融和那个射频消融的一个优缺点，大概做一个简单的一个总结。谢谢张主任。
好，谢谢啊，我用中文讲，麻烦你翻译啊。那个目前国际上这个消融用的比较多的，在脊柱上用的是射频消融。那我们这个中心呢，是从应该是03年应该是13年开始用微波联合骨髓仪。那为什么采用微波呢？因为微波和射频相比呢，第一个，它主要其实在疗效上两者应该没有太大的区别。那么微波主要的优势呢，因为它升温速度比较快，它治疗时间比较短。那么我们一般的单次消融，我们一般大概是3到5分钟。但是你如果用射频消融的话，大概得15分钟啊。它就是射频消融，它这个比较慢，其他来讲应该差别不是太大。
Okay, so I'm translating. Dr. Zhang said that internationally RF is more commonly used on the ablation of spinal disease, but in his center they've been using microwave ablation since 2013. And in his opinion, actually the result of the microwave ablation and RFA ablation, there are not much difference, but Dr. Zhang thinks that microwave ablation, its temperature can rise very rapid, like in a very fast speed in a short time, and mostly in a single ablation they use they ablate 3 to 5 minutes in a single session, but in RF it may take more than 15 minutes. So this is Dr. Zhang's opinion, and he thinks other than that there are not much difference.
Anyone else wants to comment on this?
For me, I don't really care. This is a heretic opinion. If it is microwave, if it is radio frequency, cryo, whatever. If I should give a message here is that nowadays in our common practice, when we are doing ablation in the spine, we are using intraoperative neural monitoring. In all cases, no matter whether we are using RF, micro, or cryo, in the spine, we are using evoked potentials during the ablation. In some cases, we have seen that it is much more sensitive even than the temperature measurement. We had cases where the temperature was below 42 degrees, right next to the nerve root, right next to the cord, but we had problems with the evoked potentials. We immediately stopped doing ablation. Patient woke up and everything was fine. Thus, we feel that it's much safer to do ablation in the spine rather than without evoked potentials.
Okay, thank you.
And I think we are good to close this session. It's been great to have speakers from across the world, from the US, from Europe, and from China. It's impressive that we have audiences going from Arizona in the US to the north of the US to China. It's been very, very interesting with more than 1,000 participants around the globe. Of course, I would like to thank CCMA and SIO for supporting us in this project and providing us the possibility to do that even in these COVID difficult conditions. And of course, ECHO for their logistical support for the platform and the help with all the logistics and the preparation. I would like David to close this session if he wants to put a word. And thank you all from very much from my part.
Yeah, thanks, Alexis. I really enjoyed all the speakers. I enjoyed the discussion. I thought that it was a fabulous session. I want to concur that it's really important to have excellent vendor support and collaborations between different parts of the world with SIO and CCMA. So with that, I think that we shall conclude, and we really appreciate everyone that participated in this webinar. Thank you.
Thank you, Professor. Thank you very much. And due to time limitation, we cannot go through all the questions. So if the audience have any more questions, please send us a email to the email address. And also, if you need a participation certificate, please don't forget to email us. And you can find our email address on the screen and the chat box. And please make sure you're subscribed to our LinkedIn account and SIO original official website to get the up-to-date information. And we appreciate all the speakers and moderators today for the excellent work. Thank you very much. Very happy to meet you all. Thank you.
Thank you.
Thank
Thank
you.
you very much.
Bye-bye. Bye-bye.
Bye.